duct junction, but it's in cystic duct. And with cholangioscopy and electrohydraulic lithotripsy, able to break it up, clear it out, and there you can see a clear cystic duct. So I just put this together last night, rather crude editing job, but I wanted to show you the kind of visualization. This is actually a different case, but very similar, with a stone impacted in the end of the cystic duct. One of the tricks is get your lithotripter probe out before you put the spioscope in the duct, because occasionally it's difficult to advance. And here you can actually see the cystic takeoff, and we're going up into the cystic duct. Now this is the last phase of the procedure, getting the stone out of the very end of the cystic duct. And it just shows the precision. Here we are all the way up to the end of the cystic duct, using the electrohydraulic lithotripsy probe to break up those stones. And then you're constantly flushing. So you want to make sure you have a big sphincterotomy that maybe balloon dilate it, so that the water doesn't pressurize the bile duct, it just comes back out into the duodenum. And here we're using this little, this is brand new, is a little three French nitinol basket that you can put directly through the scope. And here we're dragging the stone out of the cystic duct. And then you'll see here, same motions we do with fluoroscopically driven baskets. Shake it a little bit and get the basket to pop around the edges. And then here we've got it pretty tightly. Then of course, you can't pull it through the scope, you just pull it out and deliver it. And there, look, there's the cystic duct clear on the common duct. That's actually, and you can see all the redness from the trauma of the procedure. And now we're just doing a final clearance of the cystic duct stump. You see the cystic duct clip there. And now after that, we're able to clear it and all's done. So there's still a role almost never for bile duct stones, and actually for us, very rarely for pancreatic stones, which we do an enormous amount of at our center because of chronic pancreatitis stone. We do all these same techniques for pancreatic stones, and it's pretty amazing how often you can clear complex stones that you couldn't clear other ways. But S-wall is a little like offshore bombardment from this World War II destroyer or battleship, I should say. And this is an older case with recurrent pyogenic cholangitis isolated to segment 6, or right posterior sector, full of stones. We didn't have spyglass then, it didn't exist. So I believe we put a nasobiliary drain in, they did S-wall, and were able to clear it. So it still has a role. What about stents? Highly recommend double pigtail stents. Now, many endoscopists use straight stents, but they migrate because stones move around. And especially if it's just stone fragments, they can migrate into the duct or they can migrate out of the duct. And if you use rigid plastic stents, they can perforate the duodenum. And see this with depressing regularity. We only use either double pigtail stents or soft straight stents. And they don't really do damage. Cook has a number of soft stents. Hobbs, as I mentioned, but general recommend 2 double pigtail stents. And the reason is we'll drain, all you need is a wick. It's not a drain, it's a wick just to prevent the stone from impacting. And if you put 2 in, it makes space. If it migrates down, the pigtail will stop it. If it migrates in, the pigtail will stop it. So here is this is going up a Billroth 2, I believe, with very large stones. Notice we've placed 2 double pigtail stents, again, to avoid, here is the afferent limb wall, and the stent is the pigtail bumping against it won't perforate it, but straight stents can. There was just a fatal such case at one of our affiliated hospitals with a migrated straight rigid stent. Altered surgical anatomy, and I'll go quickly through this because I want to stop in a couple of minutes. But we used to do enteroscopy, but it's brutal and it almost always, about half the time, can't get there after 3 hours. Then we did laparoscopic access to the gastric remnant. And I don't know, or I'll ask at the end how prevalent Roux-en-Y gastric bypasses are in Pakistan. Hopefully not nearly as common as they are in the US. But the new thing is EDGE, or endoscopic ultrasound directed transgastric ERCP. Took us a while to really buy into this. We know we do an enormous amount of interventional endoscopic ultrasound, but the concern was weight gain. And what you do is put a lumen opposing stent in the, let me just move my, I'm just moving my screen. You put a lumen opposing stent using endoscopic ultrasound, usually through the staple line, although you can actually do it through the jejunal limb into the excluded stomach, and then you can do a standard ERCP. Now, the problem with that is everybody's done this enough, has had this experience of, especially when the stomach's been completely transected, is displacement of the lumen opposing stent and staring into the peritoneal cavity. But I wanted to show you a case. This is from 2 weekends ago from, most of us in my mutual trainee, Nabil Azim, did this solo on a weekend. It's a gastric bypass patient in septic shock, and did a one-step EUS guided Axios, did the ERCP, right away, found all these stones and pus, and then very commendably didn't think it was a good opportunity to do vigorous stone extraction, because that, by the way, could dislodge the lumen opposing stent. So he put in double pigtail stents and a nasobiliary drain. Was very, very skillful. The concern is, and our current fellow has a paper out, if you're going to do this, and you can leave the lumen opposing stent, and I know you guys have other types than Axios, leave it in for at least 3-4 days, then go back, do the ERCP, it's safer. If you do it all in one session, there's a definite risk of dislodging. But you know, if it has to be done, you do. And then gallbladder drainage, you can do transpapillary, or now the new kid on the block, which we do rarely, but transduodenal or transgastric puncture with the US and placing a lumen opposing stent to drain the gallbladder into the duodenum. Here's looking in the gallbladder through that fistula. Just don't do it if the patient's a surgical candidate at some point. Don't do it if they're going to get a liver transplant. So surgery, I'll just end on surgery, is for patients who have huge common duct stone burden, who still have their gallbladder in, occasionally recurrent bile duct stones that just keep forming and keep forming and keep forming. And then recurrent pyogenic cholangitis, formerly known as oriental cholangiohepatopathy, where there's a diseased lobe of the liver that's atrophic that fills up with stones. So here's an example of a massive, massive stone burden. And you know, you can clear this out after 3 or 4 endoscopic sessions, but this actually was recurrent stones. So this patient needs probably transection of the bile duct, clearing all this out in a Roux-en-Y. Or if you're worried about stone recurrence with that, there is still maybe a role for a choledochoduodenostomy. But and then this is recurrent pyogenic cholangitis of the left lobe. It's this is actually, although dilated, it's an atrophic lobe packed with stones. Not only will these stones recur if you clear them out, but this is a pre-malignant condition, risk of cholangiocarcinoma. So ideally, left hepatectomy. So that's all my reflections from the University of Minnesota. I'll stop there. Thanks so much for your kind invitation, and I'll stop there and get off. I'll stop the screen share then.
Thank you, Marty. Thank you very much. Thanks for an excellent lecture. It was very useful for all of us and useful for all the participants. There have been lots of questions which have been put by various participants. First question is, when do you consider removing the PD stent if procedure has been done successfully? Do you do it immediately or wait for a few days or leave it there?
Well, that's a really good question. There are really good data that if you put a PD stent in, you should leave it, because premature stent dislodgement can lead to late onset pancreatitis. And the only necrotizing pancreatitis I have caused that I know of in the last 6-7 years was just that. It was a PD stent for an ampulectomy that fell out probably within the first 8 hours after the patient was doing great, and he necrosed his 2/3 of his pancreas. I know Rob Hawes had a similar case because we just, last time I was in Orlando, we discussed that. So we know you got to leave the stent in. There was also a randomized trial from Indiana 20 years ago that showed that if you put in a PD stent for a pre-cut and take it out right away, they get 20% pancreatitis if you leave it in 2%. So now, will NSAIDs, rectal NSAIDs, mitigate that? I don't think so, because we see about 6 to 8 severe neck pancs a year from around our region that we have to do intervention on, and one of whom almost died, and they almost never involve a well-placed PD stent, and they all got rectal NSAIDs. So I think you need the PD stent to protect against traumatic severe pancreatitis in a case like that. And then you just leave it in. What we do is we tend to use long unflanged stents. We use Hobbs stents, 411, 49, they're flexible, but they have no internal pigtail, and they essentially all fall out in a month. I mean, we get an x-ray, but if patient goes back far away, you don't really have to worry that that's going to be there. You can also use short stents with an inner flange, and they fall out most of the time, but not always. You should follow those up. But it's really worth it. All you have to do is see one horrible necrotizing pancreatitis, and you'll be convinced that it's worth putting in 10 or 20 stents to prevent that. And that's about the number needed to treat to prevent severe pancreatitis. It's really not that many. And it does require some, we are obsessive about following up PD stents, but if you put unflanged stents in, they pretty much always go. Long answer to a short question, but Mustafa knows all about that with me.
I guess
needed. There's another question. Do you prefer leaving PD stent early once the wire's gone into the PD and you've done the papillotomy, or you leave it towards the end of the procedure? And if
very good question. I put it, the case I showed early in the talk was what we do. If we get a wire in the PD, we leave it there. It really helps you find the bile duct. and it doesn't destroy tissue planes. I'm leery of any cannulation technique like banging guide wires causing intramural dissections or early pre-cut that destroys tissue planes. Leave the wire there. Once you get into the bile duct, I put the PD stent in right away because it can be very difficult to find the PD after biliary therapy. Very difficult indeed. And in general, you don't want to do vigorous biliary therapy over an indwelling pancreatic guide wire, because A, that can fall out, B, it can traumatize the pancreas, and worse yet, traumatize the pancreas, then you lose access, then you can't find the PD again. All of these, we've evolved putting the PD stent in right away. Now, data, the only data that really come close to supporting that, again, is from Sham Verda or Julu, at a randomized trial in sphincter of Oddi dysfunction patients, and it really does make a difference. Stent first cut versus cut stent. But it just makes sense. Also, like I said, if something, I like to have a plan A through Z, not just a plan A and maybe a plan B. And once in a blue moon, you get bad bleeding or even a perforation. If the PD is stented, you can aggressively treat that. You can put a covered metal stent in if you have those available. And that, if you don't have a PD stent in, is very risky. In fact, I think our one death in the last 5 years from ERCP was exactly that, for stone disease and in an elderly patient. And metal stents without PD stents in that setting with a normal pancreas can really cause pancreatitis. So that's why I do the PD stent first. Again, another long answer to a short question.
Well, there's another question on large balloon dilatation. Rather, there are quite a few questions on large balloon dilatation.
Yeah.
The first question: what's the risk of crushing small stones against the CBD wall? And
very good question. That's excellent.
And
yes, there's definitely a risk of that. So what I do is push the stones up out of the way of the balloon. So I'm glad, that was a great question, and I should actually add it to the talk. So especially when you have multiple stones, soft pigment stones, when you're obviously you've been in the bile duct, you've done a sphincterotomy, do a distal balloon occlusion cholangiogram, and just push the stones up to the middle of the duct, or at least out of the way of the dilating balloon. And don't sink the dilating balloon too deep. Very good question.
And when you say that these CBD stones are too big to be taken out in a conventional technique, by just looking at the ultrasound, MRCP or CT, meaning by mapping?
Well, it's all relative. If they're above a narrow duct, if they're, it's always worth trying mechanical lithotripsy. Is that pretty widely available? But do most endoscopists in Pakistan have access to through the scope basket mechanical lithotripsy?
Yes, I think almost everywhere.
Yeah.
Do have.
Great. So, there's no harm in trying that, but you're going to have trouble with a small distal duct, like a funnel shaped duct, impacted large stones, intrahepatic stones, all those things. So it's worth a try, and then put stents in. Typically that's what we do. We actually seldom go to intraductal cholangioscopy the very first session. Usually if we can't get stones out first session, we'll do large balloon dilation, all that stuff, try lithotripsy, place stents, and then bring them back. I don't know, what about you? Do all of you go first session to, cholangioscopy spyglass for bile duct stones? If,
I'll just chip in. No, in our practice, we exactly do what you said. We would just try whatever we can in the first session and then go
right,
to spyglass in the next session.
right.
It's a planned thing, so we know what we're going to do.
Exactly. And part of the reason is there's often a lot of debris floating around after you do a first session. Also, fresh sphincterotomy and all that, like to let everything heal, drain. The stents can help break up the stones too. And it's cleaner, better results, and no worry about, doing a long spyglass.
Professor Marty, what is your technique to remove a difficult stone in one of the sexual ducts in the post-liver transplant patient?
Yeah. Well, Mustafa is like the expert on post-transplant. He's published a lot on that, and he's at a very large transplant center, like at least double the size of our transplant center. But it's like anytime you remove a stone above a stricture, you need to dilate up the stricture first. And if it's post-transplant, in an early post-transplant, we like to be very gentle, just like to establish drainage with stents, and typically multiple stents. More than one is better. Even if it's smaller stents, I think multiple stents move around, and they also create space for debris to drain better than one big stent. And then go back. And then once you're out a couple of months, you can do aggressive dilation and spyglass and all that. But what's neat with four-way cholangioscopy, four-way steerable, is you can really get into every liver segment individually. You can explore the whole thing. And with intrahepatic stones, there are often little stones that you can't see with cholangiography. So and you can often just flush them out or pick them out with whatever through the cholangioscope.
How do you tackle?
Can I ask a question, please?
Sure, please. Sir, go ahead, please.
I don't know if you can hear me. No.
We can hear you.
Okay. Thank you for a fantastic talk. Large stones in elderly people who are not very surgically fit candidates. Where do you see the role of just stenting them and not doing anything more?
Yeah, I mean, it's always that was an option that was established very early in ERCP, and I was like the second generation of people to do ERCP. The only thing there is, I really recommend double pigtails there, because again, straight stents are going to migrate, and more than one, so 2 double pigtail stents. I mean, the problem is, it often works. There's data on it, but it often works. And then you don't really have to change them if they're double pigtail stents, because what they do is they act as a rail. It's kind of like a stick in a doorway, prevents the door from slamming shut, but it doesn't. So that's definitely an option, especially if it's a fragile patient and you don't have access to advanced lithotripsy techniques. I think it's a great option to have. And that's actually what we do, as we were saying, the first session anyway. And we have the luxury of having access to all these advanced techniques, but and then there are patients who get recurrent stones even after you clear the duct, and that makes perfect sense. So I don't want to go over time. Whatever you see fit here. I'm free, but I know it's evening there, and
Maybe we can go for another 5 minutes if you're okay with that, Marty.
I'll go all day. It's you guys I'm concerned about. You know me. I'll talk till till everybody's
Well,
gone to bed.
but I think overall, I mean, I always enjoy your talks, and this is like an updated version for me, so I enjoyed it, and I always learn. I think most of the people in attendance have learned, and there's some very positive comments. So maybe another 5 minutes. I'll comment on two things you've already talked about. One was the PD stent issue. You know, in Europe now they do have the biodegradable pancreatic stents. They should be coming out more widely soon. So maybe that'll allow people to feel more comfortable about putting in PD stents if they have reservations about follow-up.
Yeah, I'm a little concerned that if they biodegrade into pieces, that the passing pieces are going to cause trouble. Have you seen data about them?
I haven't seen data. I've heard about them being trialed in Europe, and I don't know what the data are. So.
Yeah, because you know what I'm saying is then you convert a pancreatic stent into pancreatic stones or foreign bodies. It depends how it dissolves. Honestly, the right kind of stents with a single pigtail in the duodenum and very long, small caliber to the tail work terrifically. And the only ones that don't fall out is if they're going through a pancreatic stricture, like severe chronic pancreatitis. Sometimes they hang up on stones and strictures. But if you're doing them for prophylaxis, I mean, we do about 400 PD stents a year. It's a lot.
Yeah.
And you just don't have to remove them. And, you know, if it's a situation where a patient can't come back for an x-ray, I think the chance of there having a problem with that type of stent is so small. I am worried that the biodegradable stent will create a whole new set of problems. You know, fragmentation of the stent in the duct, damage to the duct. Because if you, even 2-week duration of a rigid flanged 5 French stent can destroy a small pancreatic duct. And actually we published that years ago. I think it was 8 patients who had permanent pancreatic injury from a rigid small caliber flange stent. 2 of them ultimately had total pancreatectomy. I mean, it was bad. So I don't know about the safety profile of biodegradables. We'll see. But, you know, they'll have, I'm sure you'll have them in Pakistan way before we have them in the US. So let us know how they work out.
I think because of the expense, the experience will remain limited in Pakistan. Biodegradable stents are going to be pretty expensive. So I'm not sure whether it is going to be used in that many number that we may be able to contribute much in terms of information.
Yeah. I mean, one interest, I'll just say though about the pancreatic stent or endoscopists giving patients rectal NSAIDs in Pakistan. Are they using that or not?
Yes, it is available and people do use it.
Yeah. Because what's happened, there's a fascinating paper in the Red Journal. Over the last 10 years, the use of pancreatic stents in the US has dropped from 50% to 5%. The use of rectal NSAIDs has increased from 5% to 50%. And guess what's happened to post-ERCP pancreatitis rates? No change or an increase. So I think that, and as I said, we have somebody in the hospital right now, in fact, scheduled for endoscopic necrosectomy and replacing 2 retroperitoneal percutaneous drains tomorrow, who had ERCP with rectal NSAIDs and no PD stent for a hilar tumor that was probably resectable in a 50-year-old. Not anymore. And the point of that story is NSAIDs alone don't prevent severe post-ERCP pancreatitis. And so I think it really behooves endoscopists to, know how to place them, especially when you're putting a wire in the pancreas, because wire in the pancreas is the dominant risk factor. Totally missed in ASGE publications, because quite honestly, I'm saying, Mustafa, I'm tired of guidelines where the authors don't read the literature. They just express opinion. They actually don't, because they don't cite the literature. If you look at the literature, for the last 12 years, every study that's looked at putting a guide wire in the pancreas as a separate risk factor, it's the leading risk factor. So once you do that, put a stent in it, and it drops from elevated risk to lowered risk.
Low risk.
And it's much more risky than contrast. It's just the ESGE, which in my opinion is more scientific, recognized that 10 years ago. But many guidelines don't. I, unfortunately, have been asked to write guidelines for ERCP complications for the American College of Gastroenterology like 4 months ago, and I've done absolutely nothing on it because I'm just other stresses you might imagine, especially in the US, but well, eventually we'll get it out. So I encourage everyone in the world to know how to place pancreatic stents. Don't rely on NSAIDs. Anyway.
I think you're also, I think you're with like-minded people, both Professor Saad, who asked the question about the elderly, and Professor Jas are of the opinion, I know from my experience with them, that PD stents are critical. There was a question on basket-related bile duct injury, like when you're trying to do mechanical lithotripsy and
almost never. I mean, it's amazing whether the stones injure the duct as much as the basket. But it's interesting you bring that up, because you know we do a lot of cholangioscopy, obviously, and what you see is road rash in there. But I actually had the privilege of using the world's first lithotripsers with Jack Venice back in the late 80s. That's how old I am. And because it was developed by Olympus and prototyped with my mentors, Jack Venice and Steve Silvas. That's the one thing I thought I'd seen or caused every complication you can imagine and more. But I've never actually seen serious duct injury with baskets. Have any of you?
Not really, to be honest. No.
Yeah, but the stones can cause strictures.
True.
And then there was another one on covered metal stents to facilitate ERCP down the line. Any experience with that?
Yeah, I mean, sure. We do tons of covered stents. For stone disease, the problem is if you just put a covered metal stent in after a sphincterotomy for stones, they migrate like slippery fish. I don't know if any of the audience ever goes fishing, but you know, when you try to grab a fish, it'll slip one way or the other. They're very hard to hold. And that's what happens with metal stents. They migrate in and out. The other problem is that if they get occluded with a stone, patient gets really septic. So that's why in general, we prefer two double pigtail stents, because again, what they're doing is, or if you need to dilate a stricture, put more stents in. And you can do, if it's actually a stricture, you can do double pigtails and straight stents. But if it's just to open up the situation, we rarely do that. Even for benign post-op strictures, very rarely do covered metal stents. Just had a lot of problems with them, even though I know randomized controlled trial shows they're about the same. What do you think?
Yeah.
Do you use covered metal stents much?
Not much, not at all. Rather,
and they're very expensive. I mean, they're like, you know, if cost is an issue, they're absurdly expensive, at least in the US, maybe. You probably have more options. You probably have a lot of Korean stents available there, right?
Do you prefer using 7 French or 10 French double pigtail?
Well, we use soft. For big ducts, we use soft. 10 French double pigtails called Sola stent by Cook, because they're very flexible. That's what we use for necrosectomy, cysgastrostomies.
In CVD, when you're facing the
Yeah, but that's what we use there, and usually a fairly short one below the stone and a long one above it, if it's a big stone. But if it's a smaller duct, then 7 French double pigtails. Depends on the size of the duct and stones.
And you said in your talk that you prefer using basket. Where exactly do you use balloon then?
Oh, well, for routine small stones, where it's just a straight duct and small stones. The case I showed with the pre-cut over a short PD stent where there was about 20 stones in the bile duct, and we did large balloon dilation. I mean, those stones came out with just suction, and so balloon works great for that. Where you can just see that you're not going to get hung up at the sphincter, but if it's a soft pigment stone or you think you're going to get hung up at a narrow duct or a sphincter, that's where you use the basket. So it's not like I don't use balloons. I think probably more balloons than baskets, but when in doubt, basket.
Perfect.
Okay, we're approaching 6:15. I know there are other questions, but I think perhaps we should wrap it up. Oh, sorry, go ahead, Dr. Saad.
No, I was just going to say we've taken already an hour and 13 minutes, so I think we should wrap it up and let Professor Freeman relax as well.
Yes, absolutely. No, thank you, Professor Saad and Professor Gas again, and thank you so much, Marty. It's I'll refer to you as Marty because you're a mentor, friend, family friend. He was my surrogate dad in Minneapolis, so I really I really appreciate you taking the time on a Sunday morning to sort of give us this talk. And as I said, it's always educational for me personally, but I know that I'm sure the audience really enjoyed it too. With that, I'd also like to thank Wilson Pharmaceuticals for sponsoring the series, Professor Gas, Professor Saad, and the rest of the panelists. Any parting words, Dr. Freeman?
Well, thank you so much. It's a real honor to be able to share thoughts. I'm sure there's an enormous expertise. I know there is among all the panelists, and especially as I said, to give a talk to my top of the class ever trainee who's taught me more than I've taught him at this point. It's been a pleasure. So
thank you very much.
Take care, and
take care.
Maybe we'll meet again virtually
or
in person someday. Someday I'd love to visit Pakistan. I'd
love to have you here in Pakistan just to show the hospitality and the areas of Pakistan. But anyway, for virtual meeting, it was really nice having you, and thank you very much. Thanks to you and thanks to your family for sparing you for the web meeting. And
no problem.
See you again.
Okay, bye-bye. Thank you very much, everybody. Bye-bye.
Thank you. Bye-bye.
Thank you.